Acute otitis media is a pyogenic infection involving the mucosal lining of the middle ear cleft. This dynamic inflammatory process develops through a cycle of events that may either resolve spontaneously or cause acute complications, such as mastoiditis or chronic suppurative otitis media. Acute otitis media commonly affects children between the ages of 2 and 6. Common causative pyogenic organisms are Streptococcus pneumoniae, Haemophilus influenzae, beta hemolytic Streptococcus, and Staphylococcus aureus. Although not common, acute otitis media occurring in neonates less than 6 weeks of age is usually caused by the enteric gram-negative organisms. Acute suppurative otitis media commences with the deposition of the causative organisms at the tubal orifice. The inflammation spreads up through the eustachian tube to involve the middle ear cleft. The normal eardrum is characterized by translucency and by normal adjacent ear canal skin. The malleus handle with its lateral process and the umbo can be clearly seen. Through the translucent tympanic membrane, the long process of the incus is visible. The first phase of acute otitis media is the tubal occlusion stage. This usually follows a viral upper respiratory tract infection. The gases in the middle ear space, being isolated, are resorbed by the middle ear mucosa. A negative middle ear pressure is generated, and the tympanic membrane is retracted into the middle ear space. The handle of the malleus swings medially, accentuating the lateral process and appearing foreshortened. The eardrum begins to lose its translucency. The tympanic blood vessels become more pronounced, and hyperemia of the drum develops. This marks the pre-suppuration phase of acute otitis media. With bacterial invasion of the middle ear, the suppurative phase develops. As pus collects in the tympanic cavity, the middle ear pressure rises, and the eardrum begins to bulge outwards. Opacity of the tympanic membrane and progressive engorgement of tympanic vessels is seen. As the inflammatory process in the middle ear progresses, the patient becomes increasingly symptomatic, with associated otalgia, pyrexia, hearing loss, restlessness, and toxic constitutional symptoms. The eardrum becomes edematous, and the definition of the malleus handle is lost. The umbo is no longer seen. However, the lateral process can still be identified. The eardrum becomes increasingly inflamed. The inflammatory process spreads to the adjacent deep meatal wall, resulting in desquamation of the epithelium. The tympanic membrane bulges as further pus formation raises the intratympanic pressure. In this ear, the ballooning of the drum appears to be greatest in the posterior-superior region of the drum. The patient develops increasing otalgia as the pressure in the middle ear continues to rise. The malleus handle, including the lateral process, can no longer be visualized. With continuing inflammation, increasing desquamation of the superficial tympanic epithelium occurs. As the pressure in the middle ear continues to rise, the blood vessels in the eardrum are compressed. Ischemia, followed by necrosis, occurs at the site of maximum pressure. This process can be seen at first as an area of discoloration with loss of epithelium. The eardrum has now lost all recognizable features, and otalgia is severe. The eardrum perforates at the area of necrosis, and pus is released from the middle ear cavity. The released tension is characterized by a sudden relief of pain with associated otorrhea. Often, the crying child will suddenly fall asleep, and there will be pus on the pillow when the child awakes. The tympanic membrane can be seen to revert to its normal anatomical position, and the handle of the malleus can again be seen. With the release of pus, resolution of the infective process begins. The middle ear is now ventilated, and the natural immunity of the patient controls the spreading inflammation and destroys the invading bacteria. Pus production stops, and the middle ear mucosal inflammation decreases. The eardrum begins to regain its clarity, and landmarks re-emerge. If the perforation is very small, the eardrum may return to normal. However, as in this ear, if the perforation is substantial, healing may occur with the formation of a very thin, new tympanic membrane. If the ear fails to heal, recurrent episodes of otorrhea and hearing loss may occur. Evidence of middle ear infection can often be seen on these healed tympanic membranes as plaques of tympanosclerosis. These scars and the healed perforation are our only clues to an epic battle of nature, fought between man and the microorganisms that share his world.